So we won't be satisfied with our opinions today, and we would like to learn more today. So why exactly the unis fail? Is it the fault in the design which is causing the failure? Or we have less knowledge about the procedure? Or the things which are using is not that good? Or it's really, really difficult to do? So we'll try to answer each and everything today and hope you are more wiser at the end of the talk. As the previous speakers has already told about the indication, I won't go into much of the details of it. Only one thing, that if there is a lateral groove on the patella, you cannot do a uni, otherwise you can do a uni in that case also. So in a uni, what we are exactly doing is we are replacing half of something and we are trying to make it work. But it can lead to some failures. So what are the causes of revision in case of a uni? Mostly according to the Australian Joint Registry, it was the lateral compartmental disease progression, loosening, and unexplained pain. The other reasons were infection, bearing dislocation, tibial collapse more in case of a poly or a polyethylene wear. Another very good paper which has shown around 3,000 UKs and a 5% revision rate. But in this case, the most important cause was the bearing dislocation. So as we all know and very nicely described before also, there is a mobile bearing and there is a fixed bearing. So once you're going to the mobile side, you try to keep it a little bit tighter. So that may cause more progression of the arthritis. And that in early stages may lead to bearing dislocations also. In case of a fixed one, it tolerates the undercorrection very much better. But the early revisions are mainly due to aseptic loosening and the tibial component subsidence. Another study which has compared a fixed versus a mobile, and actually there is no superiority of one over the other. Also, we need to understand that the lateral and the medial compartment are not the same, as previously also described, that on the lateral side, it is more convex, the LCL is more laxer, and on the medial side, you have a medial pivot. So once you're using once you're doing a uni on the opposite side, on the lateral side, you should be aware of all these anatomical variation. So this is fundamentally not the same condyle. So you have to be understood that what is going on the lateral side, and you have to know that. So the early causes of the progression, it is the most common cause, which is the mid or late term cause of a revision. Most of the time, it is because of improper patient selection and overcorrection. It's a very good paper by Kennedy in which he had basically gone through the tibia and he has divided the tibia into multiple zones. So as you can see, if it is falling in the zone 2 or zone C, then it is giving the best results. Once you go on the medial side, it causes more excessive loading on the medial side. And once you are overcorrecting, that may lead to medial instability also. 116E is 5-year follow-up. It has shown that mild varus is good and it is giving very better scores in case of a UKR. It's a case example in which there was a 50-year-old female. She had a medial chondroplasties before and then went for a bilateral Oxford. And this was the post-operative X-ray. 6 months post-operatively, she developed a pain on the right side and MRI was suggestive of a lateral meniscus tear. Arthroscopically, the tear was found and it was debrided, but she still continued to have pain over a period of time. After 6 years, she was converted to a TKR. So what are the recommendations to avoid early lateral progression? So you have to initially examine the patient properly and there should not be any lateral compartment involvement. Radiologically, as previously described, on valgus stress, you should have at least 5 to 6 mm. You can do MRI, which is showing a normal cartilage intensities on the lateral compartment. But surgically, there should be no or minimal soft tissue releases, optimize the implant positioning, and don't overstuff the meniscus bearing. The other cause of a dislocation is while you're operating, if you do a MCL damage at that time, there can be a bearing dislocation. If there is a flexion extension mismatch, it can also lead to a bearing dislocation. The component malpositioning, impingement of the implant with the soft tissue or the bone, and ultimately over a longer period of time, loosening may also lead to a dislocation of the bearing. So 62-year-old patient, he had an Oxford 9 years back. He presented in the ER with this X-ray, and as you can appreciate, there was a bearing dislocation in this. So he was revised for the femoral component and only the bearing was changed. The tibial component was good, so it was kept like that. The other cause of revision is mechanical loosening. Again, the causes are mostly the undercorrection of the deformity, the component malalignment, ACL deficiencies, or excessive tibial slope. How you can see that on an X-ray, that if you see that there is sclerosis, is absent in the X-ray, and over a period of time, the radiolucencies are increasing. So that shows that there is loosening. Also, the position of the component can change over a period of time. So initially it was in varus and then it subsequently changed into the valgus one. So this is showing that there is loosening present. Other important cause of a loosening initially was the thickness of the poly. So it should be at least 6 mm, and we are getting with all this means oxidation process and vitamin E supplementation and all. Now the polys are better as compared to how it was before. So reducing the conformity of the design is also one of the causes of a polywear. So we should be very much aware of that. 63-year-old male patient who had a left side uni 6 years back. He started having some pain and there was effusion in the knee. On the X-ray, this was the X-ray, and it was on revision. You can see there was femoral loosening present. And then this was also converted to a TKR. The other causes of revision are mainly the fractures which can occur intraoperatively, and that may be because of the osteoporosis, especially in Indian populations. Also, the impact force and direction can also lead to fractures. So how you can mitigate that? You should use light hammers. You should avoid deep saw cuts. You have to preserve the posterior cortex. Adequate slot for the keel should be there, and vertical cut by the apex of the spine. So these procedures, if you follow, the chances of fracture are really, really less. And if at all you find a fracture intraoperatively, either you can use a screw or you can buttress it with a plate. But in the post-operative period, if you find such thing, it is mostly revised to a TKR. So now you have decided that you want to revise it. So how you are going to do that? Either you can do just a poly change in a bearing dislocation, or you can do a component revision to a UKR, or you can complete it into a complete robot and you can do a TKR. So what are the challenges at hand while you are converting a UKR to a TKR? Is basically the exposure. You can use the previous incision. The bony cuts with implant in situ is very much important. And the component removal should be at the cement and implant interface.
30 seconds.
Okay. Okay. And if you are doing, then you can just see on the lateral side, you just have to take the minimum possible cut, and then you can do it into a TKR. Also, the rotations you can mark initially, and mostly a revision to a CR or a PS is possible. If there are any bone defects, you can use wedges and graft. So to summarize, you have to do very little of soft tissue releases. The minimum thickness of the poly should be around 6 mm. Proper patient selection is really, really important. Slight varus alignment is good. If you are initially starting to do, you should do fixed bearing more as compared to a mobile one. The management of osteoporosis is also important. And also, if you are revising, it can be revised into a TKR very easily. So we would try to go from our failures to success. And thank you so much for your patient listening.